Thank you very much, Will. Our first speaker this afternoon is Ms. Rohini Bajekal, a nutritionist with a unique blend of experience in both the food industry and nutritional science, and co-author of Living PCOS Free. Based in London, Ms. Bajekal has worked extensively in Mumbai, Singapore, where she developed a passion for making plant-based food accessible for all. Her academic journey is equally fascinating, having transitioned from studying theology at Oxford University to achieving a first-class master's degree in nutrition and food sciences. As a board-certified lifestyle medicine professional, her evidence-based advice on nutrition and healthy lifestyles has made a significant impact to her clients, healthcare professionals, and the wider public. Let's give a warm welcome to Rohini as she shares her insights on managing PCOS with a lifestyle approach.
Thank you so much, Kartik, for that lovely introduction, and to the entire My Health Specialist team and Nick and everyone who's helped put today together. So I'm really excited to present on polycystic ovary syndrome. I'm just going to leave this here so that you can see the main resource that kind of encapsulates everything that we're going to discuss today. And this is a real whistle-stop tour through polycystic ovary syndrome, which is a really complex condition that is something that is underreported, underdiagnosed, and is not talked about enough, whether it's with our family members, friends, patients, colleagues. It's something that all of us should be passionate about. We definitely have someone in our lives living with PCOS, whether it's our patients, our sisters, mothers, friends, cousins, aunts, or employees. So I won't go much into about myself, but I'm a nutritionist, a lifestyle medicine professional, and published my book, Living PCOS Free, with my mother, who's an OBGYN and has been in the NHS for about 40 years. And I also run my own practice, and I've personally been following a vegan diet or whole food plant-based diet for about 15 years. So just the learning objective for today, the main role is to understand the role of nutrition and lifestyle medicine in polycystic ovary syndrome. And you might be thinking, what is the connection there? That, as you'll come to see, this is a really big part of PCOS management. So the PCOS problem, this is the most common endocrine disorder worldwide, and we know that it affects at least 1 in 10 girls, trans men, and non-binary folk. And in some subgroups, it's as high as 1 in 4. For example, in South Asians and in people living with infertility or living with higher body weights. But 3 in 4 remain undiagnosed. And part of the problem is it's so difficult to join the dots in PCOS, and that's why GPs play such a key role, because they're often the first person that someone comes to when they're struggling with PCOS symptoms. They may have gone to see a therapist for their anxiety or depression, or a dermatologist for their skin problems, and a gynecologist for their irregular periods, and then they're left kind of questioning, and no one's able to join those dots together. It's also a complex genetic trait like endometriosis, and is thought to start in utero with certain changes that develop there, although we don't really understand exactly what causes PCOS. And fascinatingly, a study that came out a couple of years ago from the UK Biobank, which looked at 175,000 men, found that men can also develop PCOS characteristics. And some of those include things like premature baldness, gaining a lot of weight around the midsection, a lot of excess hair growth. And if they've got sisters or mothers with PCOS, that might be a clue. So it does also affect men potentially. And there was a massive economic meta-analysis that showed that PCOS and its associated costs and complications cost the US economy $8 billion in 2020, which is absolutely staggering. So diagnosing PCOS, it is a constellation of symptoms. There's not one clear cause, as I mentioned, and it's a diagnosis of exclusion. And it's really important to mention that because you've got to rule out several things. And they just published in September an updated guideline from the international kind of management of PCOS. And they put hyperandrogenism a little bit higher up in terms of its importance. So there are different criteria whether you're diagnosing teenagers versus adults. adults. In adults, they need to have those clinical signs of hyperandrogenism along with the irregular cycles, because obviously polycystic ovaries on ultrasound are just more common when you're younger. In adults, you want to kind of go through these steps and not everyone might have those clinical hyperandrogenism signs, things like the excess facial and body hair growth, scalp hair loss, and adult cystic acne after the age of 25. But going through these steps can help you get there. If you're seeing things such as a lot of rapid facial hair growth, enlargement of the clitoris or other things, that might be a sign of virilization. If someone has been dieting or is underweight or doing a lot of excessive exercise, you want to look at hypothalamic amenorrhea. So you really want to kind of go through all of these things. But there's a concern sometimes that people say, oh, is it being overdiagnosed? But actually, as we know, 3 in 4 are underdiagnosed. So yeah, 75% of people with PCOS don't have a diagnosis. The symptoms of PCOS are really wide-ranging, and every single person with PCOS is an individual and should be treated as such. But some of the most common symptoms, or the ones that immediately would strike probably everyone in this room, are those irregular or absent periods, with cycles typically being sort of sometimes 45 days long, 60 days long, but it's not coming in a predictable interval. And it is important to, obviously, people should see their GPs if they're not having a cycle every 3 months. And that always requires investigation, even in the very first year of starting your menstrual cycle. Excess facial and body hair growth, we know that's more common in certain groups like South Asians, but if it's causing distress, it needs to be looked at. Acne, especially around the jawline, and cystic acne that won't kind of be cleared by simple things, scalp hair loss, excess weight. We know that a lot of women with PCOS are living with excess weight, and they can have a tendency to gain weight, particularly around the central area. Insulin resistance or prediabetes. Fertility problems, there's a 15-fold increase in fertility issues, although reassuringly, most women with PCOS who want to have children do go on to conceive. And it does frustrate me that sometimes in the media it's reduced to just simply a fertility issue. It's a whole body condition. Psychological issues are also really distressing in PCOS. Anxiety, depression, often, we live in quite a society where there's a big emphasis on appearance and quite patriarchal and racist ideas of what beauty standards are that can make it really difficult if you're living with PCOS. You're also 7 times more likely to take your life if you have PCOS, and there's a higher risk of OCD and eating disorders, particularly binge eating disorders. And it's thought that the excess androgens like testosterone are quite appetite stimulating as well. So there are real biological mechanisms at play. Sexual and relationship dysfunction, and often that's seen at higher levels if they've got a lot of excess facial or body hair. Sleep disturbances are more common. Sleep apnea it's actually common regardless of BMI. Even in lean PCOS, you can have sleep apnea where your breathing stops and starts while you sleep. So another really important reason why people need to be talking to their GPs. In terms of the possible drivers of PCOS, insulin resistance is the main driver in most cases, and insulin stimulates the ovaries to produce those excess androgens. So we also see raised levels of IGF-1. Excess weight can be a trigger in some, and most are living with clinical obesity or overweight, but that also does sort of reflect the UK population that can be at sort of higher levels as well. There's an unclear relationship. We know that there's those biological mechanisms that make it harder to lose weight when you have PCOS, but a third of people with lean PCOS also have increased intra-abdominal fat on MRI scans. So that's why the lifestyle and behavioral modifications that I'm going to talk about are helpful regardless of body weight. And yeah, about 20% of women with PCOS do have that lean PCOS, and you do occasionally see it in kind of lower weights, like underweight or borderline underweight as well. But hypothalamic amenorrhea should be ruled out for sure. In terms of the lifestyle management, many people are unaware that that's the first line of treatment to manage and treat PCOS and its associated long-term risks. And that's set out by expert groups and international guidelines, by ESHRA, by Monash, by NICE. There's an increased risk of type 2 diabetes. If you carry excess weight and you've got PCOS, over 50% of women will develop type 2 diabetes by the time they're 40 years old. That is staggering. Metabolic syndrome, higher risk of gestational diabetes, which of course carries long-term risks, including increased risk of cardiovascular disease, increased risk of womb cancer, sleep apnea, non-alcoholic fatty liver disease, cardiovascular risk. There are more studies needed in this area, but we do often see an altered lipid profile with higher LDL cholesterol, raised triglycerides, raised blood pressure, and again, higher rates of preeclampsia and pregnancy. So I've just got a couple of case studies because I have heard from my parents who are both surgeons that GPs love case studies. So this is just a couple to illustrate. Again, it's that diagnosis of exclusion. Here, the person is living with BMI in the obese range, and they do have oligomenorrhea, but they're wishing to conceive. And obviously, it's really frustrating when you're trying to conceive and you're not having regular cycles, so that has to be addressed. And you can see there that LH is higher than FSH. We do see that in PCOS. The FAI is higher. SHBG is also on the lower side, and we know the contraceptive pill and healthy plant-rich diets can increase SHBG. And on the ultrasound scan, polycystic ovaries are noted, and that is that pearl-like formation that you see on the ultrasound. And the new guidelines show that you need to have at least 20 or more follicles on at least one ovary to be noted to have polycystic ovaries on the guidelines. So definite for this client, there's a lot of different things that you can do from the kind of medication side, but also with the lifestyle changes, which are going to help them have not just get pregnant, but have a healthy pregnancy and a healthy outcome. In terms of this case study, a lot of people might not realize that this person is actually considered overweight by the BMI scale. There's a lot of issues with BMI, but there are different ethnicity-specific cutoffs for BMI. So a BMI of 23 is actually just on the borderline, is considered overweight. And the person is South Asian. We do see more PCOS in South Asians and have those typical classic PCOS irregular cycles and a lot of those clinical symptoms. And they try to follow a ketogenic diet, but they're always struggling. They start binge eating, and we know that's more common in PCOS. And these restrictive diets that cut out healthy food groups, such as complex carbohydrates, also encourage a lot more inflammation in other areas. So, for example, we know that there was a study done that showed that while we know PCOS, people with PCOS have dysregulated cortisol metabolism, we know that low-carb diets exacerbate that. So whilst there are many different ways to lose weight, I definitely want to promote a way of losing weight that also helps you be healthy and reduce the risks of all the things I've already mentioned, those long-term health risks. And yeah, again, polycystic ovaries noticed on the ultrasound. In terms of weight, I have an entire chapter on our book dedicated to discussing weight with patients, which is such a sensitive issue, and it can be really triggering if you have PCOS and you've struggled with diets your entire life to be told, go away and lose weight or come back when you want to have a child, which is often the narrative that we see in the media and things. But we know that weight loss can help. We know that modest weight loss of even 5 to 10% in PCOS can help restore natural ovulatory cycles and improve pregnancy rates. And we know that it helps with reducing androgens, improving metabolic risk factors, body composition, hyperandrogenism. And it's important to say that recommending weight loss as the only goal might not be appropriate given that there is an increased risk of eating disorders. So that's why I'm a much bigger fan of recommending those lifestyle changes, which we're going to talk about in more detail. It's also key to say that there's no one diet that is recommended for PCOS in the national and international guidelines. A variety of dietary approaches can work, but obviously I recommend a plant-predominant way of eating for PCOS for these reasons. We know that in the UK, only 1 in 10 adults is meeting the recommendation for fibre. The RDA for fibre is 30 grams. Fibre is only found in plant foods. And whether it's a Mediterranean style way of eating, which is rich in plants, or a fully plant-based way of eating, there's lots of different ways of having a plant-rich diet. But it helps with all of these different areas, whether it's helping to sustain weight loss and management, which can be so hard, lowering those inflammatory markers, improving oxidative stress and improving immunity, improving the lipid profile and gut dysbiosis. When they've done studies of women with PCOS, they found less beneficial gut bacteria. And that is really key. There's been so much discussion about the gut microbiome that actually it's something that really affects women with PCOS. And this way of eating is also naturally lower in advanced glycation end products, which I've got a slide on as well. So the key adage is really focus on color. I don't expect everyone to be eating, this is the sort of way that I eat most days. Obviously, it's not perfect. I encourage progress rather than perfection and meeting the patient where they're at. Not everyone is going to be able to achieve 10 to 13 portions of fruit and veg. We're also in a cost of living crisis. So I also do a lot of work in the community to encourage people to have frozen food. We know that frozen berries are actually higher in antioxidants than fresh. Some canned food, having batch cooking, going to the supermarket late in the day when you get discount deals, and build gradually, go low and build slow. I'm also a huge fan of things like intact whole grains, which we know reduces the risk of inflammation, type 2 diabetes, and these intact whole grains are also lower in glycemic index. There's a lot of discussion about lower GI, which means that it raises blood sugar less sharply. So things like barley, brown rice, all of these foods. Smoothies are a great vehicle to get veggies in, and we're going to talk about when to eat as well. When it comes to AGEs, glycotoxins, these are glycated proteins. They're produced in the body, but we also consume them through the food that we eat. Obviously, cigarettes should be totally avoided because they do damage ovarian reserve, but they're also smoking and cigarettes kind of increases the AGEs. But high AGE foods includes beef, pork, poultry, cheese, and ultra-processed foods, think of things like kind of crisps and crackers and stuff like that, whereas low AGE foods are those whole plant foods, those whole grains, beans, vegetables, and fruits. And in PCOS, women might have twice these circulating AGEs of women without PCOS. So simple things like avoiding barbecuing and grilling food, having more steaming, sauteing, poaching, and lowering the intake of AGE foods. And brown rice and mushrooms are particularly good at pulling AGEs out of the body. These are also shown to kind of damage arterial cells. They decrease fertility rates. So high levels of AGEs have a real impact on chronic health risk. Eat in line with circadian rhythms. There is circadian rhythm disruption in PCOS. And circadian rhythms, a simple way of thinking of it is sort of like your body's internal clock. And because of that, we know that there's high levels of circadian rhythm disruption in PCOS. It's also exacerbated if you're a night shift worker. And I assume many people in this room have experienced night shifts and kind of staying up late. That can really affect kind of your hormonal health. So morning light exposure, whether it's a 10 or 15-minute walk, is something I tell all of my clients to do, whether it's just eating breakfast in the garden or getting out, getting moving, and eating more of your calories earlier in the day. I'm quite anti this whole trend of skipping breakfast. And I think rather than thinking of intermittent fasting, time-restricted eating, where you eat more of your meals, larger meals earlier in the day, a larger breakfast, lunch, and a lighter dinner. And that really, really helps with supporting restorative sleep, which often is disrupted in PCOS. So I recommend, as a nutritionist, a food-first approach. I think it's more practical, accessible. We need to think of everyone and their different ability to access things. A lot of the recommendations with PCOS on TikTok and Instagram are all about supplements, and everyone always wants to know if there's a magic supplement. And the truth is, this is a very unregulated industry, but we know that vitamin D levels, that when they're low, can exacerbate a lot of PCOS symptoms, and making sure that vitamin D is adequate can help improve reproductive function and insulin sensitivity. Obviously, everyone should be supplementing with vitamin D at this time of the year. That's the official guidance from the UK government. But with PCOS, they're more likely to have lower levels. Inositol naturally occurs in whole grains, fruits, beans, and nuts, and it's a vitamin that's been kind of put into a supplement. Many of you may have heard of the buzz around inositol, and it shows a lot of promise for improving fertility rates and ovulation rates. And you want to kind of get a ratio of 40-1 D-chiroinositol to myo-inositol. I go into supplements in a lot of detail in the book, but it is something that shows promise in both lean and overweight PCOS. And algae-derived omega-3 supplements, it can be particularly helpful for inflammatory cystic acne for some people, improving insulin resistance, lowering LDL cholesterol. There's a great meta-analysis on this. Just a nice little tip is spearmint tea. It's, costs pennies. A couple of cups a day was shown by Grant This is a traditional cultural practice in Turkey where they showed it actually decreases excess facial and body hair growth, but just a nice way to enjoy herbal tea. Magnesium, zinc, chromium have also shown to have promise, but there's evidence against calcium supplements and fish oils, although of course we do want to eat calcium-rich foods, dark leafy greens, tofu. Soya is something that I eat 2 to 3 portions of a day, very beneficial for PCOS in reducing inflammation, improving ovulation rates, improving the altered lipid profile. And there's a concern about soya having hormones, which hopefully we'll come to in the Q&A if someone asks. But soya is safe, it's healthy, it's safe for all genders, it's fantastic in PCOS. And I recommend, obviously, whole or minimally processed forms of soya like tofu, tempeh, edamame beans, rather than having the more soya sausages and things like that. That's a once-in-a-while treat. With a prenatal, they need 400 micrograms of folic acid and higher dose than those who have excess body weight. And if they're on an oral contraceptive, then it is recommended to actually take a multivitamin, multi-mineral supplement as well. All 6 pillars are key in managing hormonal health. It's not just diet. Nutrition is the cornerstone, but it's the reason I went into lifestyle medicine is understanding that all of these different pillars play such an important role in PCOS management and work together to really help the patient. So when it comes to nutrition, it's that prioritization of whole plant foods with water as the drink of choice. There are no health benefits to be gained from alcohol. We know that even having 3 drinks, 3 units of alcohol a week, increases a woman's risk of breast cancer by 15%. It's a neurotoxin, increases sleep issues. There's no benefits to be gained. Same with smoking. With physical activity, this is so important in PCOS, and I love resistance training for that because resistance training or strength training really helps to improve insulin sensitivity. And PCOS is the most commonly diagnosed menstrual disorder in Olympic athletes, which I thought was very cool. It was a positive note to add in our book. The latest guidelines suggest 250 minutes of moderate intensity exercise per week. HIIT activity does suit some people with PCOS. You shouldn't put them off doing HIIT exercise because it can really help with that, cardiovascular health and everything else. But some women with PCOS don't do too well doing HIIT. So mixing it up, having some yoga can really help because of that mind-body connection and improving kind of body image and self-esteem. So I like to mix it up in my own routine. When it comes to sleep, prioritizing a regular sleep routine, which is easier said than done, but trying to make it a priority. And obviously this is difficult if people have young families or they're caregivers. When it comes to stress management, identifying those stress triggers and finding ways to release stress. We live in a very stressful world. 89% of women in the UK say that they feel chronic stress. So trying things like meditation, breath work, yoga, psychotherapy, walking in nature, talking to a friend, yoga, lots of these things can be free of charge and easy to access. Avoiding those risky substances, especially when you have a higher risk of those chronic lifestyle diseases and PCOS. And positive social connections. I think it's so wonderful that we're all coming here today. I was so looking forward to it, and having a community, whether you're a health professional or having friends that you can really open up to and talk to. It could be, I'm a member of certain online groups for PCOS that have been hugely supportive to me, and community clubs and book clubs. So my PCOS story, one of the reasons I wrote this book is I told my mum, don't write a general book on women's health. Let's write the book that I wish that I had. I struggled so much with PCOS when I was at university. This was a picture of me at Oxford. I got very into, binge drinking and partying, and often found that my PCOS was just like, my cousin's laughing in the background, was like, my PCOS was really out of control, and I often wouldn't leave my room for 2 or 3 days at a time because my acne was so bad, and I really, really struggled with all of those things I've already discussed, the anxiety, the self-loathing. It was a very dark time for me, and it was really fun addressing my lifestyle that I saw incredible results. I was on the contraceptive pill for years, which really helped me. There's a lot of stigma around the oral contraceptive pill, but I think it's important to say whether or not you need medication, whether or not you need surgery, this is true for all health issues, lifestyle medicine will always have an important role to play, and this is so important for PCOS. I was also diagnosed with severe endometriosis in December last year, which I haven't shared more publicly, but it's important. The reason I'm mentioning that is that for a long time it was overlooked because a lot of people don't necessarily realize you can have PCOS and endo, and I was one of them. I didn't really know they could go together, but about 10% of women will have PCOS and endometriosis. So don't just assume, and often these things can cluster together. I always say autoimmune diseases are like a packet of crisps. You can never have just one. So yeah, do look for those other things, and look for things like thyroid issues and things that can be more common in PCOS. I didn't have time to go into everything today because I do want to have some time for Q&A. And I just want to end on this quote. If you listen to your body when it whispers, you won't have to hear it scream. And I think all of us can benefit so much from listening more to our body, the little signals it sends us throughout the day, and definitely encouraging our patients to do so and to get help early. So little kind of note about my book. I do have a few copies today. It's available on Amazon, but obviously I encourage supporting more independent bookstores. And this has so many things from real-life composite patient case studies, hundreds of scientific references, recipes from my own kitchen, a 21-day plan, Mythbusters on absolutely everything. But thank you so much for listening. I share a lot of tips on my Instagram. I'm not as good at TikTok as my mum is, who's in her 60s, but I also am really happy to answer questions. I'm going to be around in the break later. If you want to come and chat to me about anything, then I'd be really happy to answer. But I think we have got about 5 to 7 minutes for Q&A, so I want to give some chance for that, so it's an opportunity for that. But thank you very much.